Hello and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for December 10th, 2025. Thank you for joining us today, and thank you to the current Osteoarthritis Action Alliance sponsors shown here who help support our work, which includes the monthly Lunch and Learn series. Now it is my pleasure to introduce today's speaker, Dr. Kristine Godziuk. Kristine Godziuk is an assistant professor of physical therapy and rehabilitation science at the University of California, San Francisco. She completed her PhD in rehabilitation science at the University of Alberta in 2019, followed by postdoctoral training in human nutrition, orthopedic surgery, and osteoarthritis epidemiology. Dr. Godziuk has a background as a clinical exercise physiologist. She conducts research on aging, obesity, and musculoskeletal health with a focus on prevention and treatment of sarcopenic obesity and osteoarthritis management. The title of today's presentation is Improving Muscle Health in Patients with Osteoarthritis and Obesity, Results from the POMELO Trial. Welcome, Dr. Godziuk.
Thank you so much. Thank you for inviting me to come talk today, and I'm excited to be here to talk about the results of our study. So this is the POMELO trial, and I thought I'd start with acknowledgements, just because for those who have run a randomized trial, we know that it's a lot of people that are involved and support that is needed. So first, I'd like to acknowledge the Arthritis Society Canada for their funding of this work. My PhD and postdoctoral supervisors who really allowed me to take charge and advance this type of project. And then this work was really supported by a patient advisory team. So these are people with lived experience of obesity and knee osteoarthritis who were involved in designing the study and throughout the study involved, met quarterly with us to make sure this was a really effective trial. And then, of course, thank you to the study participants. So as a background, most of us know that obesity and knee osteoarthritis have interconnected developmental pathways, and whether this through mechanical joint loading or metabolic and inflammatory influences, we know that this is a growing issue. We see that there's higher OA prevalence and faster disease progression in people who have a BMI above 30, and increased complication risk when people proceed to have joint replacement, particularly when BMI is above 40. And what this has led to is a lot of uncertainties about best practice management for individuals who have these concurrent chronic health conditions. But what's happening is we know right now in current OA clinical guidelines, we have a one size fits all approach for this patient group. And really, based on BMI, everyone is recommended to lose weight. And this is really based on thoughts that, if you decrease body weight, you'll reduce mechanical loading on the knee. There's a lot of uncertainty in the evidence behind this, whether, what magnitude of weight loss is needed, the persistence of benefits, and whether it's just pain improvement and, how long these things type of sustain. There's also uncertainty about whether, for, the inflammation and metabolic impacts, like with weight loss, can we decrease that? And in some patients who may not have these present already, what are the, distinct advantages of weight loss? And we also know that, weight loss is recommended before arthroplasty in order to decrease complication risk, but there's really unclear evidence regarding this. And a lot of the problem surrounds this is based on how we define who should lose weight. And we really consider BMI or body mass index as that approach. And so here's an example. We have 3 people with a BMI of 35, and really we give the same recommendation for everyone. And we know that BMI, most people are aware that their BMI is, more likely a measure on an individual level. It's a measure of body size, and maybe it has value as a population metric, but, it has poor sensitivity and specificity for adiposity related health risk in an individual person. It overlooks the heterogeneity of obesity and overlooks the relevance of muscle mass, which is really what I'm going to be talking about here. Now, we've known BMI is not great, and we've always talked about, well, other things matter, like where we carry body fat. And we've often used this fruit analogy of like an apple or a pear, where you carry your body fat relates to metabolic consequences. But I'm going to, expand your thoughts around this and add a new fruit analogy with the pomelo. And here's an example of a pomelo beside a grapefruit. Pomelo is a large citrus fruit and comes in lots of different sizes, but it's usually quite large. And you don't always know with the pomelo, though, how much fruit is inside until you actually open it. And often, you might be surprised that there's not a lot of fruit inside. And sometimes there's lots. So it's something I've always thought of this great analogy for sarcopenic obesity, where you don't know. Someone could have a bigger body size, but We don't know how much muscle is inside. And it really highlights this importance of body composition. So if we go back to these three people that all have the same BMI, but yet if we actually look at their body composition, we see quite different amount of fat and muscle mass. And it's really this person on the far, left with who has low muscle that we are most concerned about missing, because they may have risk factors for, or may have pre-existing sarcopenic obesity, important clinical syndrome where someone has low muscle mass, low strength, and high fat mass. Now, there is growing evidence around the importance of sarcopenic obesity, but this is often missed when we just think about BMI. And we know that people that have obesity with sarcopenia, compared to those without, have poor quality of life, decreased physical function, higher rates of disability. If they go in to have surgery or stay in the hospital, they stay longer, their recovery is longer, and they have increased complication risk, including risk of mortality. Now, we've conducted a few studies in patients with NEOA, and we found, like in those who have a BMI above 30, more than 1 in 4 have this condition of sarcopenic obesity, but we're not recognizing it. And so, again, we're missing this group and providing the same recommendation to them. Now, there's lots of factors that influence muscle and strength loss. We know that as we get older, the risk for this gets higher, but other factors such as, inflammation potentially related to obesity or other conditions that can drive muscle loss, physical inactivity, nutrition, and even changes at the muscle level. So this is a really complex condition. But when we think about these kind of broad overlying risk factors for loss of muscle mass and strength, we can't forget that osteoarthritis adds this exponential increase on this, where people are affected by joint stiffness, pain, leading to inactivity. There's inflammation as well related to OA. So it really puts this perfect storm for overlapping and cumulative risk factors for the development of muscle loss, strength loss, and sarcopenic obesity. Now, there is some evidence in the OA literature already showing that this patient group is at high risk for changes in muscle health. So this study looked at changes over 4 years, and they're looking at cross-sectional area using MRI. And here you just see this decrease in quadriceps cross-sectional area over 4 years in patients that have NEOA, and decrease or an increase in quadriceps intramuscular fat tissue, so kind of the marbling in the muscle. And both of these have led to symptom worsening and driving increased proceeding to knee replacement. So really showing this natural history of this decline in muscle health in this patient group. This study also looked at changes in muscle volume with weight loss in NEOA, and really found that people that kept a constant weight didn't change their weight. They had lost this muscle volume. But when we see patients that lose weight, there's an exponential increase in these changes in muscle volume. And for some people, this might not be a problem, but we want some caution in that. We want to think about how we prevent too much muscle loss, is particularly in this patient group with NEOA. And I kind of want to frame this as this is a group that's high risk for decline in muscle health. And we know already above age 50, there's this normal decline in muscle mass and strength and function, but some factors may punctuate that decline and lead to increased or earlier disability. And I'd like to think here, or hope convince you that OA is really an important condition that will punctuate that decline. And we need to be critical and think about, when does weight loss potentially also accelerate that loss, and when do we need to use some caution? And I'm excited about the recent, the literature is growing in this area about the importance of muscle mass, muscle composition, and this overall body of muscle health, because we've known for a long time muscle is an important functional organ for movement, balance, posture, strength, all really important in OA for joint stability. But we don't always think about its importance as a metabolic organ. So the amount of muscle you still have for all these other endocrine immune function roles is also really important. So this is all really critical when we think about our patient population with OA. And currently, weight management in osteoarthritis is really focused on percent weight loss. And I think this is suboptimal treatment approach. And we may be putting patients at risk for loss of muscle mass, risk of weight cycling, where they regain weight, and primarily that occurs in fat mass, not in muscle. And so this increases that risk of sarcopenia with aging. And I'd like to think of, we need this improved way where we talk about targeted goals of treatment, where we may try to reduce adiposity, but also improve muscle health. And if we can optimize muscle mass, this will minimize risk of development of sarcopenic obesity with aging, and improve patients' function and quality of life. And with this, we know that resistance exercise and nutrition are really key components to influence this improvement in body composition. And that really led us to design this prevention of muscle loss in osteoarthritis trial. So now I'll dig into what we did in the trial and what our outcomes were. So the goal of this study was to evaluate the feasibility and acceptability of a multimodal behavioral intervention that was designed to increase muscle mass and improve physical function compared to usual care in adults with advanced knee-OA and a BMI above 35. We specifically chose this BMI category because it's a marginalized patient group in the existing literature. Often individuals with a higher BMI are not included in these type of intervention trials, potentially due to imaging restrictions or concerns that they won't, that they have more severe obesity. So we knew that this was a gap that we wanted to address. And we also wanted to include patients that had advanced knee-OA because this is a group where, again, weight loss is a primary recommendation. So this, our inclusion criteria for the trial was that BMI above 35, advanced knee osteoarthritis. So we did enroll patients actually at an orthopedic clinic, patients who were attending their first clinical appointment to see an orthopedic surgeon regarding joint replacement. And in Canada, where this trial was conducted, there's long waits for joint replacement surgery. And based on, at the time, BMI cutoffs for surgery. So a lot of patients with a BMI above 35 were not eligible for surgery and were directed to participate or encouraged to participate in the study. Patients could be between age 40 and 75 years. The study enrollment began in 2021 and was completed in 1 year in terms of enrollment, and then patients were followed for 9 months. And we randomized individuals who were enrolled into 1-to-1 ratio to usual care. And again, this group is told to lose weight based on, again, if you want to proceed to joint replacement, you're going to need to lose weight. And we know weight loss is going to be beneficial for your knee osteoarthritis. So these are clinical standards of care that were provided at the orthopedic clinic. And they were provided with, exercise suggestions, an opportunity to see a dietitian if needed. And then the other group was randomized to a 12-week targeted multimodal intervention. So we had 25 randomized to each group. So I'll talk a little bit more about this 12-week muscle health focused intervention. And I want to highlight that there was no discussion of weight loss. And in fact, we really focused on a weight neutral approach for this. And so the first component was progressive resistance exercise. This was a whole body resistance exercise encouraged 3 times per week, and it was guided by an exercise physiologist. They had an initial consult and then follow up every 2 weeks with the exercise physiologist. They could attend in-person exercise sessions, virtual support, or self-paced. And all equipment was provided. So we gave participants dumbbells and exercise bands if they wanted to exercise at home. They also received personalized nutrition support from a registered dietitian. So they had a baseline consultation to target the recommendations for them. Then they could attend 6 virtual biweekly group education sessions over, video conferencing. And the nutrition recommendations were focused on protein intake and a balanced diet, lots of different variety of food groups, focused on satiety and, regular meals, and an isocaloric diet, which means no weight loss or no caloric restriction. They also received arthritis self-management support through 6 virtual group education peer discussion sessions led by an occupational therapist. So these nutrition and self-management were alternating each week over the 12-week period. So here's the layout of how the study began. Patients initially came in and had their baseline assessment and were randomized. They either went to the intervention group for 12 weeks or the usual care group. And the usual care group was not restricted. So they were able to enroll in things like the GLAD, exercise for arthritis program. They could see a physical therapist. They could do anything that they would normally do to manage their OA. Both groups attended a 3-month interim assessment appointment, and then both completed a 6-month unsupported maintenance period. So neither group received any intervention support during this time. We just kept contact with patients to encourage retention to the end of the study. And our final assessments and primary outcome were at 9 months. So at each of these assessment visits, patients completed surveys about their satisfaction. They had a body composition assessment by DEXA. We did strength measures and physical function. And then they also self-reported physical function, pain, quality of life, and self-efficacy to manage their OA. Our study participants, we had 50 enrolled, 75% female, which is common in this patient group. Age range from 48 to 75, and a BMI range from 35 to 52, with a mean of 42, which again is a lot higher than we see in a lot of intervention studies for OA. 32 completed the full study at a 9-month follow-up, a little bit less female in the end, but otherwise the demographics remained the same as in the enrollment. So our co-primary outcomes for this trial were feasibility and acceptability. We were trying a novel approach here. So we were looking at feasibility of intervention completion and intervention adherence. And we had a priori targets that we set. And so we met these targets where 80% completed the study and 74% adhered to the intervention, which was attending, the 12-week sessions and exercising 3 times per week based on their, logbooks that they submitted. We also looked at acceptability through a self-reported satisfaction score, and we see a greater satisfaction in the POMELO intervention than the usual care. But I think what's most telling is on that surveys they completed, they could type in their open-ended responses to questions. And so we did some qualitative analysis of this to identify themes. And we really see this acceptability in the POMELO where people reported improving, like I'm stronger, I'm fitter, I have less pain, my knee pain is reduced in general, or the program won't regenerate the damaged knee, but has improved my energy levels and ability to move around. Whereas we see this theme of worsening in the usual care group. My knees are much worse. Knee pain has gotten more severe, affected my ability to exercise and more difficult to walk. The same again, we see this resilience of coming out in the POMELO intervention group. I have more positive attitude, feel more in control, definitely had a positive influence, even emotionally, which I think is really interesting. Yet the usual care group reported uncertainty. They're trying weight loss, but regaining their weight. Life is very unpredictable day to day. So I think this is, really supports the feasibility and acceptability of this type of intervention. So in terms of our secondary outcomes were physical function and quality of life, and this change in muscle mass, which appendicular lean soft tissue measured by DEXA is a surrogate measure. So I'd like to highlight what we see at the end of this POMELO intervention at 9 months. This group had improved physical function. They maintained their strength. So it stayed the same as at the beginning. They improved their quality of life and they maintained their muscle mass. But contrarily, this usual care group had no change in function. They lost strength. They had worse quality of life and they lost muscle mass. And I think these are the things we want to really highlight, that this loss of strength and loss of muscle mass, this group gets worse. This natural history of these health conditions puts people on a downward trajectory. And by using this type of intervention, we can prevent muscle and strength loss. Some additional outcomes we looked at, whether, change in body weight, body mass index, and fat mass. Was this better in that usual care group who are actively trying to lose weight? And we see that there's no between group difference, which really suggests that the POMELO intervention led to improved body composition compared to this usual care group. Just as a brief, kind of interesting that we looked at these individual changes in muscle health. And here we use really, strict criteria for who might have sarcopenic obesity. So we know that if someone's positive in this case, they really have a severe muscle and strength loss. And you see in this usual care group, we see this worsening muscle health where 1 of the 16 developed sarcopenic obesity only in that 9-month period. So again, this concerning natural history. And in the POMELO intervention group, we see improved muscle health in many of the patients, but not all, suggesting how even this type of really targeted intervention we may need improved personalization and more, maybe higher amounts of intervention in some patients. So in terms of conclusions of this trial and future considerations, we see that it's feasible, acceptable, and shows greater efficacy than usual care to improve physical function and quality of life. This is a promising approach to improve muscle health and reduce disability risk in this high risk population that has a worse trajectory for muscle health. So I'd like to kind of wrap this up by saying, how do we start to put muscle health in the spotlight in OA, particularly for patients that have a higher BMI? I think first we need to recognize this high risk for muscle health declines and think about how challenging this is to reverse. As an exercise specialist, obviously I am interested in this, how we use resistance exercise and how it may be underutilized in some cases. But we need to know that as you get older, it's harder to regain this muscle after you lose it. And I just show this trial, which I love. It's a 6 month intervention in adults above age 60, and they exercise 3 times per week over 6 months. Again, a really long-term intervention, 3 times per week. And even in all that period, they gain a kilogram of muscle. So if you lose a lot of muscle, to gain it back, it's going to take a lot of effort. And we know the anabolic potential in patients as they get older is muted. So we need to be concerned about loss of skeletal muscle that may, narrow the threshold of muscle loss that can lead to disability. So this is something we need to always be thinking about. And there's suggestion that when patients that have OA, this increase in muscle mass may even be further blunted. So here in this systematic review found maybe the difference was only like half a kilogram. So I hope this highlights that we need to prevent muscle loss, not wait till after it occurs. And I really think we need more balanced discussions about weight loss in osteoarthritis. We can acknowledge there may be potential positive impacts where you may improve your joint pain and your mobility. You may be able to postpone or avoid joint replacement surgery. But there may be potential negative impacts, particularly if you lose a lot of skeletal muscle. There's a risk for malnutrition depending on how you lose weight, a risk for weight regain if you, whatever method you use to lose weight, you stop and we know you'll regain primarily fat mass. And this may all contribute to a development or worsening of sarcopenic obesity. And this may lead to worse health outcomes in some individuals. So I'd love to see a future where we offer this more precision weight management concepts in osteoarthritis, prioritizing muscle health, identify patients who are already at risk for low muscle mass or low strength before we tell them to lose weight, and think about how we can use these type of interventions in combination to best meet these outcomes for patients. And this is becoming a really important topic while we have these new, more effective medications for obesity and how they can be used in conjunction with behavioral intervention approaches like nutrition and resistance exercise. Now, really important part of the output of the trial, which I was really enjoyed doing, working with our patient advisors, we developed these 2 animated videos to really start talking with patients and providers about strategies to prevent muscle loss in osteoarthritis, and even just awareness of how you need to be concerned that you're not severe caloric restriction can actually accelerate this, and what there's some exercise and nutrition approaches. So these are available on a YouTube here, and I'll make sure that Katie can share links as well to people attending if you're interested to watch these videos or share within your communities. And as well, these are QR code links to the trial outputs, the main trial results, which were published in the Journal of Cachexia, Sarcopenia, and Muscle, and then the study protocol. And that we did publish the results of our patient engagement in the design of the intervention as well. So these are available if you're interested to read more. And yeah, I'm here to answer questions and really engage in discussion. If this is work that we are continuing and planning a larger trial, and we're always looking for patients who this resonates with and who may be interested in joining our research team for future work. So please feel free to reach out to me if this is an area that you're interested in. And otherwise, yeah, I'm happy to answer any questions.
Great. Thank you so much, Dr. Godziuk. That was a really fascinating presentation, and I loved the POMELO reference. It was a really helpful visual. Um, we do have some time for a few questions. We do have some coming into the chat. I encourage anyone else in the audience to type your question into the chat, and I will read them aloud. Going to start with the first one that came in. Fascinating study and results. How useful might POMELO treatment be for overweight folks with OA knees, and how did you measure ALST and quality of life?
Yeah, thank you for that question. So ALST is appendicular lean soft tissue. So that's when we use DEXA, it uses 2 like X-ray beams to measure fat mass and bone mass. And then the subtraction of that is lean soft tissue, which can, it includes organ mass. So it's not always a great measure, but by using appendicular lean soft tissue, which is the lean soft tissue of the arms and the legs, that gives us a better surrogate for muscle mass. So there are published cut points on criteria for when it's considered below a threshold for low ALST, and it's often adjusted by weight in this population. I think the other question was around quality of life, which we use the EQ5D. which is often used in a lot of population studies. And really, we tested this trial in patients who had advanced knee OA, and a lot of the patients said, "Well, I wish I had this earlier in my OA journey." So this is something we're thinking about in a larger trial. And how do we implement this in an earlier stage OA disease process for knee OA?
Thank you. Gonna jump to one, just a clarification question. What is the difference, if any, between muscle mass versus skeletal muscle?
Well, skeletal muscle, it's like muscle, yeah. So it's about the amount in kilograms of muscle. Skeletal muscle would be any contractile skeletal tissue in the body. So sometimes I use these terms interchangeably, and I know there's a lot of discussion in the literature now about like how do we make sure we're always using really precise terms. And that's where even when I talk about appendicular lean soft tissue, it's a surrogate of muscle, but may not be a direct measure of that. So yeah, those are really great things to consider when we talk about body composition assessment. I do want to highlight for this work, we use DEXA, and it may not be the best measure of skeletal muscle mass or skeletal muscle amounts, like volume, etc. But it's very clinically accessible, which is really our goal in this, to think about how can this type of intervention approach be more scalable. So if we think about using MRI and other more advanced measures, those aren't always available for research centers and clinical settings.
Thank you. Next question. Excellent presentation. For those at the highest risk, BMI over 40, how aggressive can we be with the resistance training intervention, considering they would typically have multiple comorbidities?
Yeah, great question. So we didn't actually we have the data. We haven't gone back and kind of looked at those differences within that group, but you could see the high BMI range we had. Now, I think this work suggests that yes, we can do resistance exercise in this patient group. We found in that 3 month or like 12-week intervention, again, feedback we have that we're hoping to publish here soon is like the outcome or patient perspectives on the end of at the end of the intervention is the exercise was very valuable for them, but they almost need a longer intervention support. So I think it suggests that this 12-week intervention for progressive resistance exercise, we might need a little bit more of an increased period for them and more support to progress over time, because they can certainly do this work, and we were able to modify the exercises to match where their joint mobility and other comorbidity conditions they had. So that was the purposeful design of having the exercise physiologist do an initial consult with them and make sure that they were approved and able to conduct the exercise. But so we can modify this, but I think a longer intervention trajectory will be even more valuable for this patient group for that exercise component.
Question here about hip OA or hip conditions. I know this study was focused on knee OA. How do you think this intervention might translate for hip OA?
Yeah, I love that. That's a great question. And it's something I haven't studied specifically, but for sure, this risk for sarcopenic obesity is also going to be high. And we also see more patients with a higher BMI, proceeding and needing, hip replacement and having advanced hip OA. The relationship between hip OA and knee OA is a little bit different when we think about obesity. It's not as clear connections, but I definitely think that this type of study could be applied in this group. There would obviously, we might need some considerations in the resistance exercise components. I do think having a lower body components of the resistance exercise was important, so it would just require some different modifications. But yeah, it would be a great population to study.
And so I know that this study is over. Are there any study opportunities going on, or how might people who are interested in participating in research get involved with your work?
Yeah, great. Well, we are in plans like securing funding, hopefully to do another trial of this. But, we have shared the results of that trial. Like those videos are a great way to like at least start to think about this. And we do, um, you know, we can start to think about how we can publish out or, share more findings about how you could maybe adopt this type of program at home. I love those questions. And I think, please send me an email if this is something you're thinking about, because this all informs where we take this next and thinking about how we can maybe make some of these suggestions scalable for people right now and share that results for people to try where they are.
This is really great. Obviously, a lot of interest in the topic. We will end it there since we're at the end of our time, but I did want to go ahead and let people know that we'll be hosting another webinar in January. That's going to be on January 21st at 12 p.m. Eastern Time. It will feature Dr. Jesse Charlton presenting What Do They Do at Home? Technology-Enabled Rehab for Knee Osteoarthritis. I will be, just as a reminder, I will be sending out a link to today's recording in a follow-up email to everyone who registered, and that will include a link to the articles as well as the videos that were mentioned earlier today. If you have time to take this quick poll before you leave, we would appreciate it. And that concludes our presentation today. Dr. Godziuk, thank you so much for your talk. It was really interesting, and we're grateful for
Thank
your
you so
time and expertise.
much. Thank you.
And thank you to everyone who attended. I hope you have a great rest of your day.